Thanks, Julian. Good morning, everybody. It's great to be back at the SSG. It's great to celebrate the 10 years of the SSG with the release of this study results. The genesis of this study came from the users of this group, and SSG has been instrumental in the study. Many of the principal investigators, site PIs for our study, are SSG members. So the ENRICH trial, the early minimally invasive removal of ICH, was a multi-center effort. It was coordinated out of Emory University Hospital, and it was sponsored by NICO Corporation that provided the trial funding. The prevalence of cerebrovascular disease is quite extensive across the country and across the world, and the mortality of the disease is staggering. If we think about the pie of cerebrovascular disease, with approximately 750,000 patients affected a year in the US, 120,000 of those are intracerebral hemorrhages. And worldwide, that represents approximately 5 million patients with ICH. When we look at the mortality of ICH versus ischemic stroke and subarachnoid hemorrhage, is substantially higher. It's 30 to 50% in the acute stage. And the survivors are faced with significant disability. And the cost of care for these patients is very high, in the order of $12.5 billion. When we look at the future of ICH epidemiologically, the causes of ICH continue to increase in our population. We have more patients with hypertension, we have aging patients with amyloid angiopathy, and we have more patients on anticoagulants than we've ever had before. So we anticipate the number of patients with ICH will continue to rise. So the rationale for clot evacuation is clear, but we assess it in 3 specific points. The first one is the control of intracranial pressure. The second one is the prevention of the expansion of the clot. And the third one is the prevention of secondary inflammation. So ICP control is the most logical reason behind evacuating the hematoma. It becomes relevant in those hemorrhages that are greater than 30 cc's. And we know we can improve perfusion pressure, which decreases the amount of ischemic injury around the hematoma. But also, very importantly, we can potentially expedite extubation of these patients and get them out of the ICU. And the majority of the morbidity and the mortality occurs in that ICU stage, with 50% of the deaths occurring because of ICU-related complications. So it is a natural indication for that. The prevention of clot expansion is another very important reason to intervene. We have a lot of data on the positive spot sign phenomenon that came out of the Mass General Neuroradiology group led by Javier Romero. We know those patients that are actively extravasating are going to have worse outcomes and higher mortality. And we frequently see that progression in front of our eyes with patients that deteriorate and expand to devastating hemorrhages. Our goal is to be able to tackle those patients and provide an opportunity to change the natural history of these clot expansions. If we look at large analysis like this meta-analysis with 5,000 patients, approximately a quarter of all patients with ICH are going to have a positive spot sign. So it's a very substantial population. The third rationale for clot evacuation has to do with the prevention of the secondary inflammatory cascade. When we have patients that present with this early hematomas, the cellular and molecular events that cause the initial deficits and disruption have a time-based continuum that, if allowed to progress, leads to this degradation of hemoglobin and blood cells with endothelial and microglial activation that eventually causes this cytotoxic and pro-inflammatory edema. And those are the patients that progress into intractable intracranial hypertension and require decompressive hemicraniectomies. We know the timeline of these events, and we know that time is critical, and that there is an opportunity to, if not stop, at least decrease the severity of the edema that happens. We know from data from the MISTI investigators that when you evacuate a hematoma, you can decrease the amount of perihematomal edema that forms, and that patients with less perihematomal edema have better neurological outcomes and overall better survival. So if those things are clear, why are we not doing more conventional surgery for intracerebral hemorrhage if it's intuitively something that we all think that we should be doing? Well, when we look at the evidence for surgery for intracerebral hemorrhage, the latest version of the guidelines published in 2022 provides us with a lot of class 1 data for the medical management of ICH. The things that we do in the intensive care unit, such as putting intracranial pressure monitors, reversing coagulopathies, treating seizures, all of those have class 1 or class 2A recommendations that support them. But when we look at the surgical treatment, the best we have is class 2A data saying that minimally invasive evacuation can reduce mortality, but it didn't support improvement in neurological outcomes, and we'll see why in a minute. And the other recommendations are class 2B recommendations, where it says that minimally invasive options may be better than conventional craniotomy to improve functional outcomes, but those functional outcomes are yet to be shown in a randomized clinical trial. So that's what the status of the guidelines was as up to last year. So conventional craniotomy for ICH was rigorously tested in 2 landmark studies: the STITCH trials led by David Mendelow from Newcastle, one published in 2005, and a second STITCH 2 study focused on lower hemorrhages published in 2013. And both studies, unfortunately, were negative for their primary outcome measure. And they were the rationale for the guidelines not recommending upfront surgery using conventional techniques. What about minimally invasive surgery? The most influential trial published by, I think we lost our slides, Heather. The most influential study that was published when the guidelines were presented was the MISTY study. The MISTY study was published in the Lancet in 2019, was a large multi-center international trial that evaluated stereotactically placed catheter and gentle aspiration, followed by the infusion of TPA. Some of the key features included the timeline of enrollment, 72 hours from last known normal. The outcome measure was the modified ranking score at 1 year. So the study showed a survival benefit, but unfortunately, the primary outcome measure, the modified ranking score at 1 year, showed a slight improvement with the surgical intervention, but that was not statistically significant. This was a massively disappointing result for a group that had been working over a decade on this approach, and with a MISTY 2 trial that had shown some very positive results. So what did we learn from MISTY 3? We had very important lessons there. As I said earlier, the mortality was improved with it. They also showed that the intervention resulted in less serious adverse events. Their average evacuation rate was 69% of the initial volume of the hematoma, but the average time to reach that volume was 3.6 days. And we also learned that patients that got to a final volume goal of less than 15 cc's had a greater likelihood of achieving a good MRS of a 0.23. Unfortunately, they were only able to reach that goal in 59% of the patients. So the natural question that followed was, had they been able to clear more hematoma or maybe do it quicker instead of 3.6 days, doing it in 24 hours, will that have resulted in a positive trial? So those questions lingered, and the next step for us was to take those lessons and put together a wish list of what would be the ideal procedure. If we could design the perfect approach for ICH, it would have to be something that met these 6 goals: have an immediate impact on mass effect, maximize clot evacuation, reduce iatrogenic injury, provide direct visualization for hemostasis, and particularly for those positive spot sign patients, decrease the length of stay, and decrease their overall cost of the disease. And that's where the approach that the subcortical surgery group has supported and nurtured over the years became a natural approach to test. So the approach was initially tried out by small groups. The MySpace registry was a multi-center 10-site registry with 39 patients that was published. The first author was Mohammed Labib in neurosurgery several years ago, and it showed positive signal. Evacuation rates were good, were over 90%, and GCS improved from a median of 10 to a median of 14. And that was an exciting thing to see. The Cleveland Clinic group subsequently published their experience with 18 patients, also showing great evacuation rates of about 96% with good GCS improvements. The St. Louis University group followed with their own institutional series, and we started to see this accumulating evidence showing that maybe there was a benefit, but of course, this was by no means conclusive, and we decided to put the approach to the test in a multi-center randomized control trial. We put together a multidisciplinary team of stroke neurologists, neurointensivists, neuroradiologists, neurosurgeons, and healthcare economists. We had a data safety monitoring board led by Mark Hadley at UAB. We had Dr. Adeoye, a neurointensivist who was in Cincinnati at the time, and Greg Campbell, who was a senior FDA and former NIH statistician. And we had 37 participating sites. Many of our principal investigators are here in the audience. And the purpose of the study was to provide clinical evidence of a functional improvement, show that this was safe, and also that there was an economic benefit when we compare this approach to medical management. The study was multi-center, randomized, and adaptive, and I'll go into detail of what that means, comparing medical management to early treatment within 24 hours of last known norm. The study was randomized in a block randomization scheme in a one-to-one fashion by location, basal ganglia versus lobar location, and by GCS less or greater than 9. We used what's called in Bayesian Statistics a Goldilocks design, which allows you to tailor the sample size to flex between 150 and 300 subjects. We had predetermined interim analysis. The first one was to take place at 150 patients, and then we would have interim analysis every 25 patients after that until we completed a full sample of 300 patients. We had early rules baked into the design. We had an early success rule. So if the treatment showed efficacy with at least 99% probability, provided that we had at least 60 patients with 180-day outcomes, then we could stop for early success. And we also had an early futility rule. So if we didn't see a difference, provided that we had 30 patients with at least 180-day outcomes, then we could stop the trial for futility. None of those two rules were met. But the key feature of the trial was the adaptive design. So what we put into the design was that you would be able to do longitudinal modeling to make interim decisions. So you could use your 90-day modified ranking scores to predict the 180-day outcomes and make adaptations to the study. And that took into consideration the age of the patients, the size of the hematoma, their GCS, the location, the time, 12 versus 24 hours. And this used Bayesian probability. And it's something that I think more and more people are becoming comfortable with, but it's certainly new for many of us. This is from one of our co-authors and collaborators, Ben Seville, who is a biostatistician from Berry Consulting. And this is a quote that I really love that he shared with me from a paper written by Don Berry. And if you look at the quote at the bottom, it says, clinical trials are the final links in the chains of knowledge and for determining the role of therapeutic advances. Unfortunately, in an important sense, they are the weakest links. The rocket ships of modern biology culminate their final stage of delivery in a wagon train. And it's something that we learned valuable lessons from the thrombectomy world in stroke. We had therapies that over and over again, our practitioners said this makes sense. We're seeing great results with revascularization, but the trials were negative. It wasn't until we modernized trial design for thrombectomy that the studies showed positivity and they dramatically changed care. So what are Bayesian statistics? So what we are traditionally used to working with is frequent statistical designs where inference is based on data likelihood. We have p-values and confidence intervals, and the p-value depends on the experimental design, how many interim analysis you're doing and what your endpoints are going to be. Bayesian statistics on the other side, they start with a prior belief, and that prior belief is data. So what we did is we took all the data from Stitch trials, we took the data from MISTI, and we took the data from several other available published data repositories, and then we created about 1,000 simulations of what the trial would be performing as to be able to create these adaptation rules. So once the trial starts and you start collecting data, every time you do an interim analysis, you update this into a posterior belief that allows for probabilistic inference about those parameters. So the posterior probabilities are not depending on the design, they're depending on the results as they come in. Both are scientifically valid approaches. So why did we choose that? Well, when we look at FDA and all the government initiatives, this is what they want us to do. There is a critical path opportunities report that was released a couple of years ago, and it said that the two most important areas for improving medical product development are biomarker development and the streamlining of clinical trials. They released a couple of years ago the 21st Century Cures Act, and there's a title specifically addressing the modernization of clinical trials, and it calls for the broader application of Bayesian statistics and adaptive trial designs. The head of the FDA said that the improved utilization of adaptive and Bayesian methods could help resolve the low success rates and the high expense of phase 3 clinical trials. And now the guidance documents for FDA for Bayesian and adaptive designs are available for anybody who wants to use it. And that's what we based the design of our trial in. So what are the advantages of an adaptive trial? Once enrollment begins, the uncertainty that comes with many trials decreases, and you're able to adapt and do modifications of clinical trial parameters as the trial results come in. Then you learn about what the optimal design is, and it increases the probability on getting the right answer at the end of the trial. But the key part about this trial is pre-specification. So none of these adaptations and none of the design can be done unless you specify what you're going to do ahead of time. So you're playing by statistically rigorous rules. So all of these adaptations are done in a blinded fashion to the investigators, only done by the DSMB and by the biostatistician. So these were our inclusion and exclusion criteria. Patients ages 18 to 80 with primary intracerebral hemorrhages with a GCS of 5 to 14. Volumes had to be between 30 and 80 cc's, and they had to be able to be treated within 24 hours of last known normal. They had to have a good baseline MRS of a 0 or a 1, and the exclusion criteria included any secondary cause, such as an aneurysm, AVM, or any other vascular source. An NIH scale had to be greater than 5 to be included. They could have intraventricular hemorrhage, but not more than 50% of the lateral ventricles, no clinical herniation signs, and anticoagulants that could be rapidly reversed for inclusion in this study. So we followed the surgical protocol, as many of you are familiar with, and use the technologies described here. And our primary efficacy endpoint in our intention to treat analysis was the utility weighted modified ranking score at 180 days. And we set a very high rule for success. So the posterior probability for success had to be greater than 97.5%. So the traditional modified ranking score used in an ordinal fashion in terms of the analysis is typically dichotomized between a 0 to a 3 or a 4 to 6, which lowers its statistical power. There's an increasing trend to using, instead of the ordinal MRS, the utility weighted modified ranking scores. These are a more patient-centered approach to the modified ranking score. If you see the weights that are assigned, an asymptomatic patient gets the highest weight, whereas a severely disabled patient gets no weight. So that doesn't give you any credit. Only really good, meaningful outcomes get the higher weights of it. And every modified ranking score that we obtained was recorded. Then we scrubbed it from any identifying information. And we had a blinded adjudicator who was a trained neuropsychologist who adjudicated the modified ranking scores for analysis. Our safety was mortality at 30 days and the change in the volume of the hemorrhage in the 24-hour CT. And this is our concert diagram. So we assessed 11,600 patients. The exclusion criteria was not met for 10,600 of them. Many were for age, for a primary cause of the hemorrhage. Volumes were out of bounds. There was too much IVH. They came in outside of the time window. GCS was above or below the criteria. They didn't have a baseline, or they had DNR or comfort measures established. And eventually we were able to randomize 300 patients, 150 to the surgical group and 150 to the medical management group. And after the second interim analysis, accrual was stopped for the basal ganglia location, and we enriched for the lobar location. And we got to a full enrollment of 300 patients after that. This is the final distribution. So we had 147 patients with an MRS of 6 months in the surgical group and 139 in the medical management group, with a loss to follow-up rate that was thankfully very low, in the order of 4%. So when the enrichment was triggered, this was based on, again, 90-day modified ranking score data and longitudinal modeling. And what our statisticians did was simulate what would happen with the data that we now had collected at that point, and played all three scenarios, enrolling basal ganglia and lobar patients, only basal ganglia and only lobars. And the best chance for achieving overall success was as we stopped enrollment in the basal ganglia group and enriched the trial with lobar patients for a remaining under enrollment. So that's what we did. This is our enrollment curve. You can see that inflection point is when we did our second interim analysis, and there was a little bit of the curve sloping down because of COVID, which made it pause for several months before we were allowed to restart. These are our patient demographics. So our mean age was 62 years. Half of the patients were female, 70% were Caucasian, and the standard comorbidities were well balanced across the groups in terms of diabetes, hypertension, a history of previous stroke, and a history of tobacco use. These were our baseline presenting characteristics. The mean GCS was 11. The mean NIH scale was 17, and the average volume was 50 cc's. The location of the ICH was 69% was lobar and 31 was in the basal ganglia. And these were our time metrics. Our last known normal to arrival in the emergency department was 3.7 hours. Last known normal to arrival, to randomization was 12.8 hours. And last known normal to surgery was 16.6 hours. Once the patients were randomized, our randomization to surgery time was 1 hour and 27 minutes. And these were our primary results. So what you are seeing in these curves is the posterior distribution of a treatment effect by location. The entire study population is in the group in purple. And what you see is a posterior probability of success of 0.98 or 98% treatment effect probability of success. The effect is driven primarily by the lobar population, which is the green curve that you see on the right side. And the basal ganglia population is on the left-hand side, and you see that the treatment effect is landing approximately at the middle. So we had patients in the basal ganglia group that benefit from the interventions and patients that did not. So it remains an unanswered question. And what you see at the bottom is our primary outcome measure. So the surgical group is the bar at the top and the medical group is the bar at the bottom. You're seeing the distribution of modified ranking scores, and you can see the significant shift towards better outcomes in the surgical group. We also analyze this in a non-Bayesian way. These are frequentist logistic regression analysis at 7 days, which is the two bars at the top, 30 days, 90 days, and 180 days. And that analysis showed that at each time point, surgery had beneficial effects in the study population. So very, very positive results. We were also able to meet our safety goal, which was 30-day mortality. The surgical patients had 9.3% mortality at 30 days versus 18.1% in the medical management group, and that was statistically significant. This is the mortality at 180 days, which was also lower for the surgical group compared to the medical management group. This is how we performed in terms of the procedure. The end of treatment volume was 14.9 cc's on average. We were able to decrease by 44 cc's the amount of hematoma that presented, and that resulted in a median evacuation rate of approximately 87.7%. Over 71% of the patients in the surgical group reached a substantial evacuation. And this is our length of stay data. So we were able to decrease the ICU length of stay. It was an average of 7 days for the surgical group versus 9.6 days for the medical management group, and that was statistically significant. And we were also able to decrease the overall in-hospital length of stay. It was 17.1 days for the medical management group and 14.7 days for the surgical group. And this was also statistically significant. The surgical group also had substantially less decompressive hemicraniectomies than the medical management group. It was 3.3% in the surgical group versus 20% in the medical group. And this was also statistically significant. We are yet to analyze the subsequent effects of what that means, but as you can imagine, having less patients with syndrome of the Traphain and requiring a subsequent cranioplasty, it's also going to result in significant benefits. Again, the reduction of volume was substantial with about 44 cc's in the surgical group, and the patients in the medical group gained an average of 4 cc's. As we know, many of those continue to bleed after enrollment. So about 4 cc's more in volume in that group. When we did logistic regression to understand what the impact was of the percentage of ICH reduction and the end of treatment volume, both of those parameters were positive predictors of success and related to the effect that we saw in the study. Our subgroup analysis looked at time, both at 8 and 12 hours, and we saw higher proportion of patients with better modified ranking scores at both time points. Unfortunately, a lot of our patients were between the 12 and 24 hours, so we don't have enough of a critical mass of patients to have more conclusive data, but there's a positive signal that we want to investigate further. At this point, we can say that early surgery was safe, but we don't have enough to say that ultra early surgery or within 8 hours is better than within 24 hours. Location, of course, lobar patients did better than the basal ganglia patients, and older patients over 65 tended to do better, but this may be confounded by the fact that lobar locations occur more frequently in patients who are older. Female patients tended to do better, and this may be related to the protective effects of estrogen and progesterone, which is something has been shown in ischemic and hemorrhagic stroke in other studies. NA stroke scale did not impact the outcome when we stratified it by the numbers that you see there. GCS was positive, so patients with a GCS equal or greater to 9 tended to do better. And volume did not change when we stratified it at that cutoff of 40 cc's. So in conclusion, this is the first clinical trial that shows functional benefit of surgical clot evacuation for patients with supratentorial ICAs that present within 24 hours of last known normal. Procedure was safe. It resulted in substantial clot evacuation. It improved the utility weighted modified ranking scores. It decreased length to stay and ICU length to stay. And it also decreased the number of decompressive hemicraniectomies. The overall benefit of the surgery appeared to be coming from the strong positive effect from the lobar location. So as you can imagine, this is not an easy study to randomize patients to consenting a family for surgery versus no surgery acutely. It's a very difficult task. We had to do this in the middle of COVID when families could not come to the hospital and see their loved ones. So we have a huge debt of gratitude to the patients and their families for participating in the trial. And this was a labor of love at every site. Every patient enrolled was a fight to get them to meet the time criteria. And we collected over 1,000 data points in our data dictionary, and we had extremely devoted site coordinators and site PIs that participated in this. And we want to thank all of them for that. So with that, I'll take any questions.
So what would you, with these results, what would you recommend for the patient with the large basal ganglia hemorrhage that does not extend to the lobe?
So in terms of safety, we know the procedure was safe. And I mentioned we saw patients that had a benefit. We cannot make a recommendation for treatment. We can point to other studies that had more balanced representation of basal ganglia. So the initial MySpace registry and the other single center series. And we saw promising results there. I think it remains a location to be studied. So I would say you have an FDA approved device and we have a procedure that is safe. I think within your clinical decision making, you can decide whether you're going to offer the intervention to your patient or not. I can tell you that at our hospital, we still offer evacuation for basal ganglia patients that meet those criteria. If we had the opportunity to revisit the criteria and design a subsequent trial, I think we were smart in following the stratification by location, because basal ganglia hemorrhages and lobar hemorrhages are a different disease. Thalamic hemorrhages are a different disease. And using the same criteria in terms of volume or time or even technology may not be necessarily the right way to do it. So I think we need to figure those things out. In our practice, we tend to limit basal ganglia hemorrhage patients to smaller volumes. So instead of the 80, we're probably putting a cutoff closer to 50. And try to intervene in those patients even sooner, knowing that it is safe to do so.
At that point, how would you make those decisions in terms of the intervene versus not?
Yeah, so midline shift was not a criteria. It was clinical herniation signs. So patients that had a blown pupil or were extensive posturing. So as long as they had an exam that was salvageable, that's why the GCS cutoff was 5 to 14. We had a lot of negative screens with patients that had a GCS of 15, for example. And in those patients, we would not be able to detect a difference compared to medical management if we intervene. In many older patients with some brain atrophy, they can tolerate substantial amounts of volume without having a deficit. So we were very rigorous in the inclusion criteria there, but midline shift was not one of them.
Thank you.